Welcome back to Reclaim Vitality, the series where we can help high achieving women take charge of their health with more clarity, confidence, and the right support. I'm Dr. Onna Lo, and today we're continuing our conversation on midlife hormone health with a topic that brings up so many questions and often so much fear. In this episode, we are talking about hormone therapy, lab testing, who may be a candidate, what has changed in the conversation around HRT, and how women can make informed decisions without getting lost in outdated messaging or conflicting advice. I'm joined again by Dr. Amy Hawkins, a licensed naturopathic doctor and North American Menopause Society certified practitioner based in North Carolina. And with her 20 years of experience, she's guided so many women through hormonal shifts with a personalized, whole person approach. Dr. Hawkins, welcome back.
Thank you. Thank you, Dr. Lowe. It's always a pleasure to be here.
Yeah. So women are told two very different stories. One says hormones dangerous, the other says they're essential and they're going to make you feel so much better. So what's actually true? What are your thoughts?
Yeah, so the hormone replacement therapy is dangerous. Conversation is extremely outdated. That is based on misrepresentation, misreporting of data from the Women's Health Initiative that was released about 20 years ago. That study it found a very high incidence of especially cardiovascular events in women on hormone replacement therapy. But the type of hormone replacement therapy that those women were on is very different than what we typically do today in a more modern approach. And then also just the data was not properly interpreted and reported in the first place. So even the risk that was shown on when women were on those hormones that are very different than what we do now, the risk was not actually as high as they were reporting. But the result of all that misrepresentation is that an entire generation of women was taken off of their hormones. And then the women who entered menopause, like in the past 20 years, were often not offered hormone replacement therapy because when that study came out, doctors basically just stopped being trained on how to prescribe hormone replacement therapy. It just was not a focus of medical education, even for OBGYNs. And so it's a huge disservice that was done to women. But more recently, we are working to correct that. So I don't know, you want to
Yeah.
take it from here and talk about how we're correcting it?
I love a couple of the points. I think one of the most, I think a lot of women now don't understand is actually when that study came out, the WHI Women's Health Initiative that was done in 1998. When it came out, they did the study for a while. They found something that was so uh, that it was affecting. It was like, wow, it really is affecting blood clots. It's really affecting heart disease. Let's stop the trial. And it was like very something that doesn't happen that often. I think
Right.
it's in the world of doing studies, right? Research. It was like something that was like, oh my God, this happened. Let's. It became a big deal, and so it was just very abrupt and aggressive, and
Yes.
and almost I would say when I was going through med school, it was like afraid. It was like you're
Hmm.
afraid, and you're taught to be afraid of the liabilities, the doing
Hmm.
harm, and then there's misinformation. You started messing up, thinking, oh, is it really for heart disease or is it really because of breast cancer? And so there's just a lot of misinformation that because we're not taught, then there's not really real information and education.
Yeah, correct.
Let's take a moment and actually talk about what is different about that study and what have we now learned, so that we can actually say, well, what's different? And if people are like, well, back in the day, those are the studies that came out that was terrible, that's not good for us. Let's actually break those down so that we can actually start, helping women when they're seeking for help and talking to doctors, they can be a good active participant. What are the fundamental differences? The first one I would say are the kind of hormones. So, what are the difference in the hormones that were used back then for the studies, and what are we using now?
Yeah, so the type of estrogen that was used in that study, or the type of estrogen, I shouldn't say used in the study, the type of estrogen that women were on who were studied in the Women's Health Initiative was either Premarin or Prim Pro, which is not identical to the estrogen that we make. So, like Premarin, for example, is estrogen isolated from pregnant mare urine. That's why it's called Premarin. So, horse urine. And so it's horse estrogen, right? Basically, in layman's terms, which is not identical to human estrogen. So we were looking at a different form of estrogen. Very similarly, we were not looking at women who were using progesterone, which is our natural form of progesterone, or our natural progestin, I should say. They were looking at women who were on synthetic progestins, which we do know carry a much higher risk, especially breast cancer. Maybe I shouldn't say much higher, but higher risk than progesterone. So women were on forms of hormones that are not what naturally occur in the human body. And so now those of us who specialize in menopause, perimenopause, hormone replacement therapy, we're very careful to use bioidentical hormones. So we use estradiol and we use progesterone rather than the hormones that never have occurred in the human body. So I think I answered your question
Yeah,
fully.
yeah. One way I like to actually think about it is there's a really great analogy that I learned in one of the lessons or webinars, or they're all webinars now instead of actually in person. Uh, Fresh strawberries versus strawberry flavored gummies.
Yeah.
They're just different, right? Like we make fresh strawberries, they're organic and they're what our cells produce. And then there's synthetic strawberry flavored gummies,
Mhm.
and they were studied on strawberry gummies, and we don't use a lot of that anymore. And so it's just even when we're interpreting the data, they are, it's not going to be as exact. Another thing that was happening at the time too, a lot of the study people were 65 to 79 years old women,
Mhm.
whereas now
Yep.
we're actually looking at women's impact of women in perimenopause to postmenopause, which is up to 65. And so it's also a very different cohort of women.
Mhm.
And one of the background too, I think a lot of women were very often, when they come to me, they're afraid of it affecting their breast cancer risk. I,
Mhm.
I want to stress that the WHI at the time actually really was looking for outcomes that are related to heart disease, blood clots, and yes, they threw in a lot of other questions. Be like, well, does it help or affect breast cancer,
Mhm.
colorectal, heart attack, strokes, all cause mortality, and then diabetes. And
Mhm.
interestingly, even back then, when it's just the estrogen only and just synthetic estrogen only, the
Mhm.
women were actually having improved heart disease, improved cancer risk, improved diabetes, and everything. And
Mhm.
it's only when it's combined with progestin, the synthetic progesterone, that they were having more incidents of breast cancer, heart attacks, strokes, clots, and that's why they stopped. But even with the
Yeah.
progestin at the time, they
Mhm.
found that it improved fractures and diabetes, which is interesting as we'll talk about why people use it now.
Yeah. Yeah. Very good points.
Yeah.
Yeah.
What are the different, I mean, now that we're talking about, right, there's fresh strawberries and it's strawberry gummies. What are the different types of hormones are there when we're talking about HRT? Because I think there's bioidentical hormone replacement and there's
Mhm.
hormone replacement, right? And
Yeah.
then there's also different types. Like what to expect when you talk to the doctor and what might be prescribed.
Yeah. So, well, I want to touch on something that you mentioned a minute ago about the increased risk of breast cancer being primarily related to progestins. So that's true. So the safest form of HRT is estradiol only, so just estrogen. But if a woman has a uterus, as we know, you have to have a progesterone on board to protect the endometrial lining from potentially developing endometrial cancer because of that estrogen being on board. If you don't have a uterus, then awesome for you. You get to do the very safest form of HRT, just estradiol only. But I also like to really ground women in an understanding that even when we add a progestin, which again is the higher risk form than progesterone, The increased risk of breast cancer, or the increased incidence of breast cancer that we see, is around about 1 per 1,000 women. We'll have an additional one case of breast cancer per 1,000 women. To give women a reference, like kind of a comparison, women who drink more than, one or more alcoholic drink per day have an increased incidence of 4 cases of breast cancer per 1,000 women. So something as simple as that increases your risk so much more than having even a progestin on board. And again, we know that progesterone is even lower risk than a progestin. So it just really helps ground women in, like, okay, I've heard all these scary stories about breast cancer and HRT, but that it helps to quantify the actual risk. So anyway, just wanted to kind of add that.
Great. Yeah.
So, a lot of us, will have a glass of wine here and there. So just, comparing your risk factors is really important. Um, so the different types of hormone replacement therapy. So, we have the non-bioidentical, and then we have bioidentical. And what bioidentical means is, again, that the hormones are exactly the same as what you naturally produce. Most commonly, that's going to be estradiol and progesterone. Sometimes women will use estrone, which is E1, and estriol, which is E3, but those are really specific purposes. So for this conversation, it's mostly going to be estradiol and progesterone. Now, there is sometimes a misconception that women are like, oh, it's bioidentical, it's natural, but actually it is still made in a lab, but it's just exactly the same as what your body naturally makes biochemically, like the actual chemical structure. I also find that there's a misconception that women think they can only access those hormones through a prescription, or yeah, a prescription through a compounding pharmacy. But that's also not true. That was true a long time ago, 2015, maybe even 10 years ago. It was much more common to go to a compounding pharmacy. But now you can access those bioidentical hormones through a standard prescription, a standard pharmacy, possibly have it covered by your insurance. So it's access is much better now. So I don't know if you want to go
Yeah,
into more
I
detail
also
on that.
actually have to also right now that we're just breaking the misinformation out there, or myths out there. It's actually, even if you don't have a good insurance, I often send patients to cash only pharmacies. There's a
Hmm.
few companies that, like, I'm not sponsored by them, but Cost Plus by Mark Cuban, or even just looking at like the, $4 programs. There are actually, or the Good RX
Hmm.
programs. It's actually very reasonable. It's
Hmm.
not cost prohibitive compared to some other medications. So I think it's important to kind of not also to take charge on seeing that sometimes if you really need something and if it really makes a difference, try it rather than feeling, oh, if my insurance doesn't pay for it, it's probably not good for me, or I'm not bad, my symptoms are not bad enough for that.
Hmm.
Often it is a barrier if people feel like their insurance is not paying for them because they're not sick enough yet.
Yeah, yeah.
Yeah. And then types of delivery, I think you'd mentioned estradiol. I was asking that question. Estradiol, I think, you know, I think topical in terms of there are
Oh,
certain
yeah. Hmm.
risks. So when we go through and talk about, well, what are the risks that we want to minimize in
Hmm.
terms of other side effects or negative outcomes? Actually, often the topical choices, which is in the form of a patch or in the
Hmm.
form of a cream,
Hmm.
uh, could be actually because it bypasses the liver, it actually has a different effect, and so it actually has it's more safe for certain conditions. There's
Hmm.
also local, it's very safe, if, and so if you have local symptoms, vaginal symptoms, you just apply it locally, and
Hmm.
that's very, very safe.
Yeah.
Yeah.
Yeah. Yeah. So it's important. Yeah. Like you said, topical estradiol is the safest route of dosing versus oral. And then, but on the flip side, oral progesterone is usually what we do. So, right. So oral micronized progesterone. So sticking with the topical estrogen minimizes your risk and optimizes your benefit. And an oral progesterone minimizes your risk and optimizes your benefit. And the reason for that, at least, you know, my approach, I'd love to hear yours, but my understanding is that you really have to do an oral progesterone to reach a systemic level high enough to properly balance, or what we often call oppose, that estradiol that you're taking. So you want to have enough progesterone to have a balance of, the estradiol to progesterone ratio to protect your endometrial lining, especially.
Yeah, actually, I was just reading an article from the Menopause Society yesterday. IUD, that is progestin only
Hmm.
IUD,
Yeah,
like Mirena, actually now has been used for up to 5 years for the
yeah,
same protection of that local, or systemic levels that actually reach to
yep,
protect. So that is an option. And
yeah,
and the truth is, this is really important for women to know. There are side effects to oral progesterone. People get
yep,
really bloated. Some people really
hmm,
can't tolerate. I have at least
yep.
20% of my patients who just get so tired, they get really moody, they get really depressed. What's your experience?
Same. It's funny you said that because I was literally going to say, wait, I forgot to mention the IUD. Yes, some women do not tolerate progesterone well, and yeah, bloated, moody, depression can develop, and breast tenderness. Those are the most common symptoms that I see with progesterone intolerance, is what we call it. And in those cases, that is the exception where a progestin, like which we've been talking, like, oh no, progestins, yay, progesterone. But in that cases like that, that's where a progestin can be extremely helpful, administered as an IUD. And because the IUD is in your uterus, then obviously it's releasing that progestin very locally, is how we refer to it. So it's staying basically in your uterus and protecting that endometrial lining and preventing like excessive proliferation of your endometrium that could potentially come from estrogen alone. So yeah, excellent point. I completely agree. Same.
Yeah.
Same.
So let's say now we were like, okay, it's don't be afraid. There's a lot more strawberries out there. You don't have to take the strawberry gummies, but if you take the strawberry gummies, it's okay because now you're educated. What do we know now? Like if you walk away saying, I heard this conversation with Dr. Lo and Dr. Hawkins, am I a good candidate for HRT? And who may not be right off the bat?
Mhm.
Do we know
Mhm.
that? Can we share that?
Yeah. So we know that, so in anything you choose to do in medicine, you're always weighing out the risk versus the benefit, right? We know we are minimizing the risk and optimizing the benefit if women start HRT in their perimenopausal or early postmenopausal years. So the recommendation is to start no longer than 10 years after your last menstrual period or beyond age 60. So that's where we see the lowest risk and the most benefit. So if you fall in that range, then you are a good candidate. You're also a good candidate if you need help managing your symptoms. Obviously, if you have absolutely no symptoms associated with perimenopause or menopause, then that's a very different conversation. Maybe you don't need HRT. Maybe that's not the choice for you. And then we also want to consider your family history and your individual risk factors. So if you have any history of clots or advanced liver disease, severe cardiovascular disease, it becomes a very important conversation on individual risk with your practitioner, because it's kind of funny because we know that HRT can prevent cardiovascular disease, and can help to prevent cardiovascular disease, I should say, and can help to prevent a lot of the things that we consider normal parts of aging. But then we get into a tricky spot where if you already have kind of advanced disease, then initiating HRT could possibly contribute in a negative way to that progression.
Yeah.
So
Um,
yeah.
a lot of the guidelines that I use, and I think because this body of study, the Menopause Society has actually done a lot of just looking at data and coming in and helping guide
Hmm.
practitioners, and also just I think as a result benefit patients. Is the
Yeah.
Menopause Society hormone therapy position statement, and they just and they would come out periodically, um, and and so it really is to help weigh some of that risk and benefits.
Hmm.
But we do know the hormones. Estradiol is FDA approved for vasomotor, which is just hot flashes, and
Correct.
bone loss, which is interesting, right?
Yeah.
You never think about, oh, just for preventing osteoporosis,
Hmm.
osteopenia itself is an
Hmm.
important
Hmm.
reason why we take it. Um,
Hmm.
but then it is a very personal conversation within the patient, with the patient and the doctor. Um,
Yeah.
who are so there is the less so there's these are the clear ones, right? Younger than 60, less than 10 years from menopause, and no contraindications to what you had mentioned with the family history and personal history. What are who are the ones that then would be less favorable, or that you have to actually pause and have a different kind of conversations? Uh,
Yeah.
what are some, yeah, if you want to share that.
Yeah. So again, just the flip side of who it's good for. So any woman over 60, then the benefit has to really, really outweigh the risk, or more than 10 years post-menopause. Any woman, like I said, with advanced liver disease, liver fibrosis, definitely liver cirrhosis would be a big concern. Cardiovascular disease. There is some conversation around, we sometimes when women have classical migraines, so migraines with prodrome, then there may be an increased clotting risk with HRT. Honestly, the newer data is coming out and suggesting that that's not as big a concern. It actually is okay for women to proceed with HRT. But again, that comes into that situation where you want to be working with a menopause informed provider, a specialist, and someone who can really help you make that individualized decision to best serve you. I also want to First of all, I want you to add to whatever I may have missed there, but I want to make sure we don't forget to talk about testosterone because, gosh, that's a big question, and
Yeah,
testosterone's all the rage.
yeah. What
So,
who are the women that you actually start talking about it to, and what do you see benefits for it for?
well, so if we're sticking to the Menopause Society guidelines, right, and what testosterone is actually approved for, then it's really only approved and recommended by specialty societies for treatment of postmenopausal low libido, which actually the official name is sexual desire disorder, right? And so when that is occurring in postmenopausal women. In reality, what most of us are doing who specialize in this phase of life is, we're offering testosterone when women are experiencing really severely low libido, even before menopause. Excuse me. So in those perimenopausal, premenopausal years. But in my practice, personally, I don't go straight to testosterone. I know a lot of influencers, highly recommend it and it's all the rage. But I will usually recommend women start with estradiol and progesterone and see where that takes them, how much improvement they have, and then kind of consider testosterone like the icing on the cake. If you still need a little bump, if you still need a little more help with your libido, maybe if you still need a little more help with energy, mental clarity, brain fog, like testosterone can be just kind of that extra little bit on top once you've already kind of determined your optimal estradiol and progesterone dose.
Okay.
So, what's your approach?
Well, first of all, I think you're just pitching for our next episode, which is actually whole foundational support that really makes your hormone replacement therapy protocol that much more effective, which is actually
Mhm.
looking at the whole big picture of everything else. So stay tuned for the next episode. And I
Yeah.
think that actually, lifestyle, diet, other things, stress management, they can really also improve your general libido, but also like that whole energy and symptoms related to having more vitality of a higher
Yeah.
testosterone. And
Yeah.
so I think that it's the salt of the soup. I'm a salty girl, so I call it salt of the soup. But yes, I think that it's really important to have that conversation. It's really easy to apply. Women starts declining their testosterone after in our 20s. So
Mhm.
it is much more declined. And the level of testosterone we have in our body is actually higher than when we have our estrogen and progesterone. Um,
Mhm.
and so it's not unsafe for us to have it. And I think that's really the lesson behind this conversation is that if we actually start talking about it and start safely understanding it, how it impacts ourselves personally, what to
Mhm.
look for, why were we worried before, then it's more easy to use it and more safely to use it effectively.
Yeah.
One
Yeah.
piece that we didn't talk about is really the vaginal symptoms too, right? Like that
Mhm.
that we could also often super save even if you have history of cancer or breast cancer or estrogen related cancer, that actually vaginal, topical use is super safe, and it's super helpful for women who are having vaginal symptoms.
Yeah, yeah, good point. Which, gosh, let's rewind the podcast episode and add history of breast cancer to the list of potential contraindications. I can't believe I forgot to say that. So, very good point. So, it's not, HRT is not completely contraindicated if you have a history of breast cancer. But it again is definitely cause for pause and an individualized conversation with your provider and especially with your oncology team. Um, so yes, but in all cases, vaginal estradiol is considered very safe and very effective for women who even have had a history of breast cancer. So when we use estrogen vaginally, um, very, very little, almost none of it is absorbed systemically. It really works locally in your vaginal tissues, and it can be extremely helpful. I mean, some would argue absolutely essential for women who are having vaginal symptoms, collectively referred to as the genitourinary syndrome of menopause. So
Mhm.
that's when we're having vaginal dryness, pain with intercourse, sometimes just pain resulting from the dryness and the thinning of the vaginal mucosa, just like ongoing pain, vaginitis. There could be a change in odor. There could be recurrent infections like BV or yeast infections. And then most concerning, it's as women kind of progress, usually this is a little longer down the menopause road where you start to get chronic UTIs because your urethral opening is in your vaginal canal. So when that vaginal tissue is thinning and drying out, then you are at higher risk for all types of infections, including UTIs, and that can become a real problem in the later years post-menopause. So that vaginal estradiol can be really, really helpful. I mean, it is the treatment for the genitourinary syndrome of menopause, and it's very, very safe. There's pretty much zero contraindication ever for vaginal estradiol. Still, sometimes I find women who either just not real comfortable with using, estradiol. Maybe they don't want to give that a try because of some remaining fears around the Women's Health Initiative, or just personal, philosophy. They don't want to go that far. In that case, vaginal DHEA can also be extremely helpful. DHEA is the precursor hormone to estradiol and testosterone in our bodies. So you can use the vaginal DHEA and then you can convert it to, the estrogen and testosterone that you need in that local vaginal tissue. And then sometimes DHEA just actually works better. It's very individualized, and that, I mean, I keep saying, and I'm probably boring you to death. It's like, yeah, it has to be that individual conversation, right? It's not a one size fits all. So, yeah, do you have anything to add to that?
I think that was really well said, is that there's so much hype right now about BHRT, and it feels like
Mhm.
it's easy to just go in and say, I want the A, B, and C's, estradiol or progesterone and the vaginal estradiol. And some women walk away be like, I just had a terrible experience. I'm not getting the same relief. People say you sleep through the night right off the bat. It is, I think it goes back to, it is an art to the science of the work. And it
Yeah,
is important to become aware for different people. And that's what the individualized approach for our practice is so important.
yeah.
We're
Great.
gonna we're gonna do a quick question about labs, and then we're gonna wrap up.
Okay.
So this is a really important one, and it's very depending on practitioners. But what about testing, right? Patients often feel like, well, if you give me all these things, are we going to test for it? What's going on? What is your practice?
Yeah, good question. Such a big question. So every single day, I get phone calls in my clinic. Women are like, I just want to get my hormones tested. I need to know if I'm in perimenopause, right? So perimenopause is a clinical diagnosis. Menopause is a clinical diagnosis. We can obviously look at your hormones. We can test your hormones, but your hormones are not the end all be all. Especially in perimenopause, your hormones are all over the place. The very nature of perimenopause, we refer to it as the zone of chaos because your hormones are up and down every day. They're not following the monthly rhythm that they did prior to perimenopause. And the further you are into that transition, the more chaotic it becomes. So a hormone test is not the whole answer and doesn't really guide treatment, especially in perimenopause. Your symptoms guide the treatment. And so testing actually, I mean, honestly, I often will test hormones because women really want that. It gives them comfort. They like the information. They want to see the data. But more important to me as a clinician is looking at other things. So when a woman comes to me with, fatigue, mood shifts, weight gain, all the things that we see, especially in early perimenopause, um, what I'm more interested in is, are you hypothyroid? Do you have an autoimmune disease? Do you have some nutritional deficiencies? So I'm more interested in ruling out other potential causes of their health concerns. And then if we've ruled out all of those, their age, their menstrual pattern, and their symptoms are matching the clinical picture of perimenopause, then we go ahead and proceed with that diagnosis and, treat accordingly. Now, as you get farther along in that journey, and especially once you're postmenopause, you will see your FSH, your follicle stimulating hormone, go up. It will increase and be in that postmenopausal range. That's obviously a really definitive measure. Okay, you're definitely postmenopause. Here we go. But before that, it's really more of a clinical diagnosis. So hormone testing is not essential. The one exception to that is absolutely, I always look at testosterone. So whenever we're considering initiating testosterone therapy, I always get a baseline testosterone. I want to make sure that a woman's testosterone is, low or low normal before initiating testosterone therapy. And I also want that baseline so then I can compare once we are doing testosterone, or once a woman is using testosterone, I should say, that we're keeping it in a safe range. So in my practice, and based on Menopause Society guidelines, and based on evidence-based care, even when you're using testosterone, a bioidentical HRT, you still want to stay in the physiologic range for a menstruating female. You ideally don't want to push outside of that physiologic range, because then you increase your risk of the negative side effects of testosterone. So like male pattern hair loss, male pattern hair growth in places where we don't want it, deepening of your voice. So things that, we tend to want to avoid. So yeah, I do that. And I always counsel women, it's absolutely essential, especially on testosterone therapy, to monitor 6 weeks after you initiate, and then every 3 months in the beginning, and then you can stretch it out to every 6 months once you kind of find your perfect dose. But it needs to be really closely monitored. And then after initiating estradiol and progesterone, I usually will monitor on, an every 3 to 6 month basis. But again, testing before starting estradiol and progesterone is not necessary.
Yeah,
That was a really long answer.
that's a very detailed. Almost, I feel like that's its own little like podcast conversation, because it is so important to realize once you are educated on the clinical piece, then we don't actually need the numbers to prove it. When we need the numbers is to be safe and to be actually guided on what we already know. And
Mhm.
I one of the best ways to actually help understand this concept is we never test a teenager when they're in puberty. They're all over the place,
Yeah,
but they're in puberty, right?
it's very clear.
And you wouldn't say, well, let's test to see if you're there yet. You're like, you're definitely there. Or we're having an inkling, it's starting. And so I think that's where we're going for perimenopausal women. We're just having enough awareness and language to promote that this is the stage, so that there's that just general wide education that we're able to say, hey, we're in perimenopause. It's a natural state that women goes to, and
Yeah.
we can support each other that way. What
Yeah.
is, as we're wrapping this up, I always end with one question. Um, if you are talking to your younger self with the wisdom you have
Mhm.
today about this topic, what's one thing you would love for her to know?
The one thing is, have the conversation. Consider your options. Talk to your doctor about your symptoms. Consider your options. Have the conversation. Don't put it off, because, again, we know that the benefit typically outweighs the risk with earlier initiation of HRT, right? So go ahead, have the conversation, make your decision, make your plan. Don't avoid it and delay it. Now's the time.
Love it. Thank you so much, Dr. Amy. Hawkins, and this is such an important conversation for everyone listening. If this episode cleared up some of the confusions around hormones and treatment, send it to someone who's been thinking about it or trying to make sense of it all. In our next episode, we are going to be talking about the bigger picture, how to support your brain, your heart, your bones, your metabolism, and long-term vitality beyond hormones alone during this period of time. Thank you so much for tuning in, and we'll see you soon.
Thank you.